Now, I would also like to mention about something about adenomyosis, because most of these patients can have 60 to 70% of these patients can have associated adenomyosis. So how to manage these patients is very important. Adenomyosis is in the uterus and endometriosis is outside the uterus. The treatment for adenomyosis is hysterectomy, but we cannot offer that to all. So adenomyosis, mostly we offer first medical treatment in terms of oral contraceptive pills and progesterone-based therapies. And then comes the role of surgical treatment that may be conservative or definitive. Or there is in medical treatment, there is a device called as Mirena, which is also widely offered nowadays. If the patient is not looking for pregnancy, Mirena can be offered because it's a contraceptive as well. Now, in conservative, we have two options nowadays. We have also microwave ablation. It's a new therapy which we have started. We use microwave technique in which we try to burn the adenomyome. And surgical option, conservative, is adenomyomectomy, either laparoscopically or robotically. We remove the adenomyotic tissue. And the definitive option is the hysterectomy. Now, ovarian endometriosis, rarely it is an isolated endometrioma. The presence of ovarian endometriosis has been reported as being a marker of deep endometriosis. In 85% of cases of chocolate cysts, there may be associated deep infiltrating endometriosis. Now, this was a case of bilateral endometriomas where she had chocolate cyst in both ovaries, but along with the deep infiltrating endometriosis involving the uterus acrals and the posterior peritoneum and other areas. This is how the uterus is suspended. The ovaries are badly stuck to each other. This is also called as kissing ovaries, and they are also stuck to the posterior surface of the uterus. So this is, now when we do cystectomy, it is very important that we try to save the ovarian reserve. There we are using vasopressin, which helps us in separating the ovarian cortex from the cyst wall. Now, ovarian cortex is the area where most of the eggs lie, and we have to be very careful when we do these surgeries that we don't damage the ovarian cortex and the hilum of the ovary, so that we can safeguard her future fertility options. Now, step 1 is identification of ureter and dissection. Step 2 is dissection of the pararectal fossa. 3 is rectovaginal dissection. 4 is dissection from anterectal wall, dissection of nodule from the posterior vaginal wall, and closure of the colpotomy. Now, this was a case of Mrs. ABC, aged 44 years. She had been heavy bleeding with painful periods, painful defecation, and painful intercourse. No intercourse for last 10 years because of pain and multiple medicine failed therapies. 6 shots of GnRH was given. In ultrasound, she had adenomyosis and DIE of pelvis and bowel. So in this case, we if you look at the ultrasound, we could find a bowel nodule. This is the bowel nodule actually. So primary posterior compartment involvement with thickened RV septum and bowel thickening up to a length of 6.4 centimeter with 22 millimeter depth, extending up to the mucosal surface and 50% of the circum. And these are, believe me, these are the ultrasound findings, and only a trained person can give you these kind of findings. Now, this was the gynecology for this patient and this cystoscopy. Now, this is the laparoscopy picture, the uterus, all these lesions are endometriosis, the white lesions and all that you can see. So in this case, we had planned for a hysterectomy because she was 44 years, menorrhagia was there, associated adenomyosis was there. So we planned for hysterectomy along with endometriosis excision. So in this case, I'm skipping the hysterectomy part and taking you to the bowel dissection part because the nodule was 6 centimeter. So we resected a portion of the bowel and rejoined the healthy ones. And 6 months, now she's 8 to 9 months post-operatively, and she is doing pretty good. Her defecation pain has gone. She can have intercourse normally, and she's having her life back. So you must be thinking why a gynecologist is talking about this surgery. Why? Because the surgery has to be complete, and we do this in our routine practice every day. So almost 6 to 7 centimeter of the intestine was resected, and resection anastomosis was done. This was the bowel segment which was removed. So pain and quality of life, lap excision definitely improves. These are the articles which have been published and they have shown us the results. Laparoscopic excision of endometriosis provides a lasting improvement in quality of life across 5 domains in improving the pelvic pain, control and powerlessness, emotional well-being, social support, and self-image. A patient who is in pain drastically improves when her pain goes away in all aspects. Now, surgical endometriosis recurrence, it depends on the surgical expertise. If the expertise is good, recurrence will be less because they can identify the lesion, remove the lesions, and they can give patient a good quality of life and enhance their fertility as well. Infertility, excisional treatment of endometriosis is associated with reduced rate of recurrence and increased spontaneous pregnancy rate compared with ablative technique. During excisional surgery, ovarian reserve preservation is very important. Excisional surgery in deep infiltrating endometriosis enhances pregnancy rates in patients with previous IVF failures and also spontaneous pregnancy rates. And there are randomized trials which has shown that those who had previous IVF failures with endometriosis in situ had good outcomes after excisional surgeries. To minimize the adverse effect on ovarian reserve, surgical treatment should be performed with specific expertise in endometriosis and fertility. In cases of young females who are not yet planning to become pregnant, it would be appropriate to offer fertility preservation such as oocyte freezing and embryo and ovarian tissue cryopreservation before surgery. Endo and bowel disease, different surgical techniques exist. For some patients, we do only shaving, some we do discoid excision, and some we do bowel excision, as I shown you in the video. DI represents endless surgical challenges at many levels. How radical one can be in order to preserve organ function, but at the same time prevent recurrence. And one super specialized surgeon can do this, or a multidisciplinary team is mandatory. So multidisciplinary team is mandatory for endometriosis management. And multidisciplinary team work preoperatively and peroperatively. Homogeneous standard of surgical treatment for DIE should be followed. So what are the take-home messages from this webinar? One is laparoscopy is the gold standard for diagnosis and treatment, but imaging can pick up most of the lesions if the person who is doing the imaging is trained. There is a poor correlation between disease severity diagnosed at laparoscopy and symptoms. A patient may have a stage 4 disease, but no symptoms or only infertility. A patient may have very crippling symptom and only stage 1 disease. The most effective lap surgical technique is excisional surgery. Lap management of endometriosis should be individualized, maintaining a radical approach towards the disease while preserving and safeguarding function of pelvic structures. This is what is my multidisciplinary team, where we all work together and all patients are taken care of by a nutritionist, pelvic physiotherapist. I have a neurosurgeon, pain specialist, colorectal surgeons in my team, and incredible nurses and all staff. I think it's time for questions.